Hi, thank you all for this invitation and for the presentations by Dr. Forrest and Dr. Skidmore. I think that, um, there's just so many thoughts spinning around, but I'm going to take a slightly different tack on thinking about a little bit more about the entry level students and immediate postgraduate and what we might need to do to um, facilitate the development of learning health system scientists. So just a few confessions and biases. My clinical background is as a pediatric PT. I am very biased toward outcome measurement. I think it is something that we need to be thinking about, having authored a textbook on it. And I do a lot of training for APTA on clinical practice guideline development with the goal of improving practice. So all of what the purpose of learning health system science is about resonates very strongly with me. I think this presentation was, Dr. Forrest's presentation was very exciting because it illustrates this very fast collaboration of institutions across multiple cultures and leadership styles to come together on aligning a common taxonomy for the data itself, methods of warehousing, procedures for data use, determining a mission for how that data would be used for training. So we don't see things move that fast typically across so many settings. And the fact that there are so many more who are jumping on board, I think is a testament to how strongly and well developed that process was. We have other large data sets and there are programs that focus on the use of large data sets, but mostly they are focused on adults. It's nice to see one developing for pediatrics. The speed of the development and the impact, the ability to bring quick studies using that large data to illustrate improved outcomes is critical. The fact that there can be this nimbleness to large data sets so that you can query pressing questions and perhaps get answers faster than those prospective studies, certainly for a cost-effective approach to gaining some understanding about where the evidence is leading us at least. I think having this consumer focus is critical. Having parents on board to help direct questions, having patients inform what's important. I think there's a model of evidence-based practice that came from the occupational therapy world that actually tips the typical triangle on its side and creates three sides to a pyramid so that we think about the qualitative input that patients can have and have that equally important to the crisp experimental studies that can be done and then the clinical outcome studies that can be done. And maybe when they all merge at the top of that pyramid, we'll actually really understand more about what we're doing. And I'm always excited when I see that there's data about kids that are being coordinated. So PedsNet is an exciting secret. I think that we need a little bit more publicity around that. I do think that this challenge of merging data across sites and synchronizing coding is our greatest challenge in this country. Clearly in countries with national health systems where there's one medical record, we can coalesce this information a lot faster. And we just don't have that option in this country. The interventions from a physical therapy standpoint are not always data driven. We are very enamored of our treatment approaches and not so enamored of standardizing how we document. And so these are going to be at odds when you try to standardize documentation and you have clinicians who want their autonomy and creativity about how to describe what they're doing. So we need to think about ways to teach a value around documentation as something more important than just a means to payment, and increasing that value of repeated measures to inform practice decisions. So having those measures really drive practice rather than choice of interventions driving practice. I do believe that in medicine, the outcomes are crisper than rehab outcomes. It's very hard in rehabilitation to titrate dosage of what we do. And so developing a taxonomy to describe what actually transpires in a visit is still part of a challenge that we have before we'll be able to have reliable data. Rehab interventions are messy cocktails. We typically have multiple treatments in a single session. We might use the same intervention and expect that it will impact several different outcomes. And we may use an intervention that has multiple names. And so depending on where you are geographically or who you studied with, you may call the same intervention something one way and somebody else is recording it a different way. So again, this issue of a consistent taxonomy is still a challenge for us. You know, when I think that we're at our 100th anniversary of the profession and we still can't come to some consistent agreement on whether we need 5 levels of grading muscle strength or 10 or pluses and minuses, or whether to use a 180 degree or 360 degree goniometer, we still have a lot of work to do in getting that general agreement. Rehabilitation often addresses multiple outcomes. And so where medical outcomes may be a little bit more objectively observed, we can titrate medications, you can look at their effects, you can look at surgical success. Rehab outcomes are a little bit more difficult to pinpoint that cause and effect impact. And with rehab outcomes, they're often moving targets. The goals may take a little bit longer to achieve, and they may change over time as the patient's potential becomes more clear. Payment is often a limit to how long we can see a patient. And so whether we actually achieve the goals fully is not always clear because there's a cost-benefit balance that both patients and payers have about how long they want to participate in services and how much they're willing to pay for those services. A few of the other challenges to think about in terms of building capacity for scientists who study rehab outcomes is this national movement of quite a number of programs that are shortening the professional physical therapy program. And so, you know, there is this tuition debt load. Salaries have been stagnant, but tuition has gone up. And we are seeing that this is impacting the need for students to get out a little faster, or at least there's a belief that we can get them out there quicker. But then that doesn't give us the time to increase some of the introduction to these kinds of research processes. Therefore, there's a little less time to enculturate interested students in research in general. And I'm not sure that traditional admissions values, there's a value on patient skills and patient access and observation over research readiness. And so our traditional admissions processes may not be attracting students who have an interest or a predisposition to be thinking in these lines. We know that there are fewer applicants nationally to PhD programs, and the DPT programs are not consistently preparing PTs to actually do research as opposed to being consumers of research. And so we have a little bit of a disconnect in terms of professionals who are coming out, who, if they're not going to pursue a PhD program, might they pursue a training program like this that would change how they perceive what their role is in the healthcare system, but they would need some, I think, strong modeling for that. And pursuit of PhDs after the DPT requires financial support and employment opportunities. I think this idea that there may be new and different roles that a learning health system scientist could take is encouraging, but we would need to really find those folks and perhaps harvest some of their ideas about what they're doing and how that might be a role model for other kinds of clinicians. So what would it take to get PTs into big data? I think at the entry level, we need to really think about a realistic curriculum on outcome measurement. We teach a lot of evidence-based practice principles, but not as much about measuring the outcomes of service delivery. We would need to deepen the curricular connection between measurement, intervention, and outcomes so that our graduates really do value the importance of repeated measures and objective measures, and standardizing the way they measure in order to document that and have a baseline for comparison. I think we need to create relevant training data sets for analysis of outcomes that can be used in curriculum. To try to get a hold of a large data set or even a modest sized data set for students who have never really looked at large data, it can be overwhelming and they don't have the ramp up time in the curriculum. So we need a contrived, contained training data set that would allow them to essentially play in a sandbox to help shift their paradigm from thinking about patients as an N of one experiment to looking at an N of many patients, and the importance of looking at trends in practice as a way of improving their outcomes. We certainly need to do faculty training to teach outcome measurement. It is not something that a lot of faculty think about. They have their research lines, but they're not thinking about system outcomes necessarily. And so we would need to increase faculty capacity as well as student capacity. And maybe by looking at some of the funded dual degree options for a DPT MS or a DPT PhD where they can fast track into a program like this, that might be a mechanism for facilitating entry-level professionals into that path. At the postgraduate level, I think we need to do a lot of collaborating with the Academy for Physical Therapy Research and possibly the Academy for Physical Therapy Education, but looking at potential training models. Guideline International Network has just started promoting a 4-module sequence to become certified as a guideline participant, a guideline author group, a guideline facilitator, and a guideline consultant. And so providing these kinds of stepped training programs might allow people to get into the track of thinking this way. And then certainly interprofessional collaborations need to occur. So I'm not sure if we'll have time for all of these questions, but do our admissions processes really attract students with research as an end goal? Is this a CAPTE issue for curricular content, that we drive it through the requirements for what needs to be in programs? And might the competencies that Dr. Forrest has laid out or the NIH research plan be adopted or adapted by COSTAR or the Academy for PT Research to help develop some of these modular types of approaches? So I think that's my time.